welcome to today's webinar brought to you in partnership with GRAIL, Eliminating Disparities and Improving Public Health, the promise of emerging blood-based multi-cancer early detection tests. I'm your host, Bobby Patrick from the Medical Alley Association, and I'm looking forward to today's discussion and learning more on this exciting topic. Before we get to introductions, let me provide a quick roadmap of today's webinar. We'll start off with Dr. Whitney Jones, who will be providing more background information on multi-cancer early detection and some much needed context for today's panel discussion. Following that, we'll jump right into the panel discussion and audience questions. So please submit those using the Q&A function found at the bottom of your screen. And with that, let's get to introductions. First up, Dr. Jones.
Hi, I'm Dr. Whitney Jones. I'm a gastroenterologist and a senior medical director for GRAIL Bio. So glad to be here today.
Excellent. Dr. Westgate.
Good morning, everybody. My name is Candace Westgate. I'm an OBGYN, as well as I have additional medical training in medical genetics. And I am the founder and director of the AHEAD Early Cancer Detection and Prevention Program at Adventist Health.
Excellent. And Dr. Lowell.
Yes, I'm Lukman Lawal. Thank you, Bobby. And I lead the health equity team for Bright Health Group. I'm so honored and thrilled to be part of this conversation today, and I look forward to really making an impact with that. Thank you.
Excellent. And thanks to each of you for being here with us today. All right, Dr. Jones, with that, I will hand it over to you to start off our webinar today.
Very good. Let me share my screen. Let me know if you guys can. Can you guys see my slides okay?
Yep, we can see them.
Great. Well, thank you again so much. It's been 50 years this year, actually, since President Nixon's famous War on Cancer proclamation. And today's talk is about further shifting from defense to offense in our battle for cancer. I'm a gastroenterologist and more specifically a therapeutic endoscopist. For the last 27 years, my schedule was filled with pancreatic cancer, liver cancer, stomach, esophageal, and yes, colorectal cancer. Not to mention the myriad complications, including blockages and bleeding from advanced cancer locally. So 20 years ago, I worked on expanding my practice into public health around the area of colorectal cancer control and have had a keen interest in genetics as well for the last decade. When I learned about the potential of a cell-free DNA-based blood test being able to detect many cancers and the promise of democratizing screening and the potential for life saves, I was compelled to join the GRAIL team. If nothing else, but a translator for the really, really smart teams of scientists, engineers, and physicians who are GRAIL and bring this technology to the real world of clinical medicine and the patients we serve. Here are my disclosures. Sorry about that. GRAIL's mission, simply stated, is to detect cancer early when it can be cured. We all have these questions about cancer. You can see, will I or my family member be diagnosed? Where is it? Can it be cured, or is this going to kill me? This is a common issue. And again, I hail from Kentucky, the nation's #1 state in incidence and mortality. And today we're here to bring stakeholders together to better understand and advance innovative, safe, and effective technology. To date, our greatest impacts on cancer care have come through both prevention and early detection of cancer, i.e. tobacco cessation and guideline-driven single cancer screenings. But as we move forward, the promise of multi-cancer early detection tests, let's go ahead and review some of these grim statistics. The human and economic toll from cancer is absolutely staggering. 8.7 million years of life loss, 6,000 deaths a year. That's a pandemic every year. And we're spending about $200 billion to treat cancer when unfortunately the results are still often too futile. And all this translates into a massive economic burden of $1.3 trillion. And most of that is due to cancers without guideline recommended screenings. But the true toll of cancer is immeasurable. It's reflected in human suffering, by the lives cut short, and by the countless loved ones who are left reeling from it. And as you can see on the right, the ACS and many partners across the spectrum know that the best way to bend the curve on cancer mortality and reduce this burden is through prevention and early detection. And so if we decide to do something about it, and we're making a decision that has the potential to save lives, We know that if we screen for more cancers and catch them earlier, the impact on survival is dramatic. 89% of people live more than 5 years when their cancers are diagnosed early, whereas less than 21% live 5 years when their diagnosis is late. And metastatic disease, which only represents about 18% of current diagnoses, translates into 48% of the cancer mortality that we see. Thus, it's critical to reduce and avoid. It's widely accepted that early detection is the key, and guideline recommended screening has reduced cancer and mortality by over 25% for certain specific types. But it's now our job to have a greater impact and detect more cancers earlier. The arrival of multi-cancer early detection testing, we now have a decision to make. Do we continue in our current state, or we do something about it? And I think that the answer is quite clear, and we wouldn't be here at this time. As you can see on this slide, 68% of deaths occur in people without recommended screenings. And 32% of deaths occur in people that have recommended screenings. So again, over in this purple are things like ovarian cancer, pancreatic cancer, lung cancer for many people who don't meet screening criteria or who are not compliant. The list is long. Thus, the pressing need to change this paradigm to provide cancer early detection for cancers which no longer, which have no existed screening recommendations. We now have the opportunity to reframe our approach from only screening for individual cancers to begin to screening individuals for cancers. And by that, we mean many cancers. Now, this data shows that many cancers are detected at late stages, particularly ones that really vex our society: lung and bronchus, pancreatic, ovarian, esophagus, oropharyngeal, non-Hodgkin's lymphoma, liver. And they almost all presented at more advanced stages than the three we see here: cervical, breast, and colorectal. But even those have advanced cancer states, and that's related to compliance issues and suboptimal uptake of screening, particularly in lung cancer screening, which is nationally at about 14% right now. And a person who undergoes a USPSTF screening exam has a 2 to 24 increased risk of being diagnosed with a different cancer in the next year than the one they were screened for. Thus, the need to change the paradigm. And over the past 2 years of COVID, we know that we've seen a dramatic decrease in cancer screenings due to COVID. And it really gives us a glimpse and some insight about the complexity and frailty of our healthcare systems, in some cases exacerbating already existing cancer screening disparities, cancer outcomes as well. So we're thankfully catching up, but we're going to be dealing with these many delayed diagnoses and their attendant late-stage diagnosis and deaths for years. And in 2030, cancer is going to be the #1 cause of death, overtaking cardiovascular disease. And it's dismal, but again, we're here to propose new solutions. Multi-cancer early detection test, also known as MCEDs. So this is how it works. And again, this is true across all of the MCEDs that are out there. At the intersection of human genomics, dramatic advances in both DNA sequencing and machine learning have occurred, also known as artificial intelligence. And this allows a literal finding of the needle in the haystack reliably, quickly, and at population scales. So all cells in the body shed DNA into the blood, including cancer cells. And it comes through a variety of factors: necrosis, shedding, apoptosis. And the presence of cancer DNA in your bloodstream doesn't mean cancer cells are in your DNA or in your bloodstream, just that DNA has escaped from those cells. And we found this out about 2015, when we identified cancer in the prenatal testing specimens from women who were undergoing evaluation. And that's where GRAIL was spun off from its parent company, Illumina. But really what they did was try to figure out, how do we assess this DNA? What's the best way to look at these mutations? And so the initial founding of GRAIL was in fact basic research and development to identify whether mutations, chromosomal alterations, or DNA methylation patterns were the most appropriate. And far and away, DNA methylation patterns, which are really primordial because they're linked to gene expression, regulation. They also identify with great accuracy where a cancer signal is originating from. Methylation patterns allow us to have accuracy of sight as well as assist with high degrees of cancer diagnosis. So GRAIL has developed Gallery, which is a multi-cancer early detection test. You have a single blood draw. which detects cancer with methylation-based sequencing, as well as the assistance of machine-based classifiers, to identify multiple cancers and also deliver with a high accuracy, and we'll talk about the performance here soon, of the source of origin for that cancer. It is meant to complement, not compete with, existing guideline-based screenings, and it detects many lethal cancers, including unscreened types, from this single blood draw. And it is designed with an extremely low false positive rate of less than 1% to avoid identifying indolent tumors or unnecessary workups, which are a major issue with current screenings. This graph really talks about the key performance feature of the Gallery test. It detects more than 50 different types of cancers seen on the right, in addition to performance in those with recommended screenings shown at the bottom here. And again, these are some of our most vexing cancers: ovarian, pancreatic, oropharyngeal cancer, liver cancer, leukemia, and lymphoma, all with an extremely low and engineered false positive rate of 0.5%. The accuracy in predicting the localization of cancer signals is 89%. And in 12 of these cancers that you see on the right, that account for almost 2/3 of our mortality in the United States, we have 68% sensitivity in identifying those in stages 1 through 3. So the goal here is to maximize the chances of early cancer detection. And you can see over here, in the routine 5 recommended cancer screenings, and we're throwing in prostate and lung here for fullness, you can see that Gallery, added at a population scale based on its performance with SEER data, identifies almost 3 times more cancers early. And these are cancers that are in people who are asymptomatic and have no risk factors. The biggest risk factor we know for cancers is age. So people who are over 50 have a 13 times risk of cancer. Likewise, people with genetic syndromes, prior cancer diagnoses, smokers, potentially other issues are going to be there as well. So you can see that when we add Gallery to the 5 recommended screening exams, again, we see that tripling, in fact, of early cancer detection, and moving cancer away from that metastatic disease and earlier is really the goal. And really, this is what I call taking molecular diagnostics out of the oncologist's office and putting them into the primary care physicians and specialists tool to assist with cancer detection. But none of this is going to be impactful if we don't really get our heads around disparities in healthcare. We want this to lessen the gaps rather than increase the gaps in disparity. And we are striving through coverage, education in the healthcare ecosystem, and simplicity of testing, a single blood test, to overcome these historical barriers. And again, these are not new to anyone. African Americans have the highest mortality rate. Hispanics and Latinos have the highest incidence of advanced stage disease, and Native Islanders and Pacific Islanders have higher rates than their white counterparts. And our test does perform. It performs similar in ethnicity across all these, and it also performs well across all ages. So again, people who are young that might have risk factors or genetic syndromes, our tests to date have performed extremely well. So we have that potential to take this to the population level and really make a difference. And what would that look like? So on the left, you'll see that modeling the detection of GRAIL. In the gray, you see where stages of cancer are diagnosed right now. And again, more in advanced stages. And again, that's because the preponderance of cancer deaths occur in those cancers without screening. With the addition of Gallery at the population scale, we can essentially flip the stages from primarily late to primarily early. And in those patients who have their cancers identified by GRAIL testing, we have the potential to actually avert almost 40% of those deaths, resulting in almost 100,000 lives saved, again, based on this model data. So as the lessons of COVID are playing out, we can ask ourselves, where do we want to be in 1 year, 5 years, 10 years? Do we want to be reactive, or do we want to be proactive? And the concern is us bringing this incredible technology, again, out of the lab, out of the oncology space where it's been used for years in cancer management, and move it into the primary care to impact population health. MCEDs truly have the potential to bend the cancer curve by helping us detect more cancers earlier. And this means patients in all communities can be cured. We want to thank Medical Alley for allowing us to participate in this forum, and I look forward to the next speakers and our Q&A question.
Excellent. Well, thank you, Dr. Jones. That was really insightful and great background info, and really provides a nice base for our panel discussion today. So I'll bring the panelists in now. And we're going to spend a good amount of our time today talking about really the end of the presentation, which is the impact on health disparities and how this technology can really help push us down the road of eliminating those. But I'm actually going to go back to the beginning of the presentation for the first question. And Dr. Jones, you addressed this a little bit with your closing comments, but I'm gonna go to you first on this question. And so we're dealing with a COVID-sized pandemic in the U.S. every year, losing 600,000 lives to cancer. And with COVID, there was a lot of regulatory flexibility and payer flexibility, Operation Warp Speed, and really unprecedented collaboration throughout the industry on technological advancements like MCED. So how can we continue to leverage this experience and develop knowledge, as well as combine it with the technological advancements like MCED to really impact public health? And again, you touched on this a little bit in your closing comments, but if you want to expand on that a little bit, that'd be great.
Right. Well, that's a great question. And again, imagine working through a problem like COVID and then not being able to apply the rules to what it will be the most high cause of deaths in America. So I think we're approaching this in several ways. Number one, I think that technology is accelerated. I came from the days when you submitted a paper, it'd be months and even a year or two before it was published. Now they're published frequently within days. So I think the lessons are learned that we can accelerate rapid change that has evidence-based modalities behind it. I think the second thing is that we're going to depend a lot on our advocacy partners out there. We are working on developing an MCED consortium of various industry, as well as people in the advocacy space, the academic space, to really try to jumpstart and bring cancer prevention to the Medicare space at the national level. Because again, you have to move things into the Medicare space before they can really be taken up by payers and other people in the healthcare system. So I think the goal is to use those lessons, make the case, which I think we have today about this pandemic size cancer death every single year, and utilize the broad partnerships to advance it. And again, to me, this is proactive or reactive. If we haven't learned anything over the last year, it's proactive. Nature's really helped. And again, we've been in this battle for over 50 years. We've never had this opportunity to expand the paradigm like we have today with MCEDs.
Excellent. Dr. Lowell, interested in your thoughts on that question and Dr. Jones's comments.
Yes, I thank you so much, Bobby, and thank you so much, Dr. Jones, for the phenomenal presentation. And my thoughts are around, I always like to view things from the health equity perspective, and how do we as leaders in this healthcare space really ensure every single step of what we do as the health equity lens. And what I mean by that is, how do we ensure that from the conceptualization of the idea to the commercialization of the product as the health equity lens with which we review how things work? And for me, the aspect of health equity, which is the diversity, equity, and inclusion, stands out. And how do we ensure within our organizations, starting from the board to the C-suite to the director levels and the VPs and all that, we have this voice of the African Americans, the Hispanics, the Native Americans, the LGBTQIA+, as well as the disabled population being represented. Because at the end of the day, if they are in the room when those decisions are being made, we don't have to go back and try to reverse engineer how to take it to the market, because they're already there when you're making those decisions. So what we are doing differently at Bright Health Group is to really come from ground up to ensure we have a close collaboration with the grassroots and really having them being represented at our advisory council levels. So all the decisions we are making and everything we're doing at Bright, we're ensuring that at least it has the lens of health equity baked into it. And I always like to say this, like, it's easier to build a great system. And luckily enough, Bright Health Group is barely like 6 years. GRAIL is like barely 5 years as well. And it's easier to really bake health equity, diversity, equity, and inclusion into our processes, our plans, our procedures, and to really run from there. It's more difficult for the 80 years organization, 100 years organization, because it's difficult for people to accept change. So for us, I think we have a chance, we have an opportunity, and it's left for us to see whether we're going to seize the opportunity and make a difference and change the landscape of healthcare in the US and make it the way we want. So I'm quite excited about this opportunity, and I see more collaborations and how we can really improve on health equity with regards to cancer, MSEDS, and all we have here. Thank you.
Yeah, Dr. Lowell, thank you for that. And we'll get into that a lot more later, and really applying that health equity lens from the beginning and the development from start to finish is critical to really not only making progress on eliminating health disparities, but making them stick. So we're not just making temporary progress while it's on the front of everyone's mind. So Dr. Westgate, I'll let you sort of round up this question, and then I'll start with you on the next one. So your thoughts.
Absolutely. I have a little bit more of a micro thought, not as great as a macro thought as my other two presenters. As a physician, seeing patients on a daily basis, dealing with the COVID pandemic, seeing those high-risk patients not coming back into the office because they're concerned about the risk of contracting COVID, having to pivot very quickly, which for the first time, honestly, in my career as a physician, I've seen healthcare do this, which has been extremely exciting, and as simple as offering virtual care to patients, and the immense improvement that's made, and the broadening of access to care. Our organization, 80% of our patients are in underserved areas, and the lack of access to care for them is drastic. And thanks to the changes that we've seen and been able to implement with COVID, we've really taken those lessons learned and instilled them in our organization's cancer risk prevention and early detection plan with the AHEAD program. And we've been able to ensure that everything is done virtually for our patients to improve access to care. Without our patients trusting us as providers and organizations, we're not going to get compliance. And without offering them tools that enable them to be successful, like, going for that colonoscopy is a difficult step, right? For those individuals who are trying to figure out how they're going to feed their family for the next week, that is a difficult decision to make, to take the time out off of work, to go and do that kind of invasive and time-consuming cancer screening test. That is not high on their list. Whereas a test like Gallery, I see this as a complete game changer, almost like the invention of the internet, and our patients having access to screening for a multitude of cancers and not just single cancer testing. This is really going to improve cancer survival and our patients' excitement of doing a test like this versus those single cancer tests.
Excellent. And before and again, I'll encourage you all to just respond to each other as well. I think that'll drive really fascinating conversation. But before I get into my next question, and Dr. Westgate, I'm glad you touched on that, on the taking time off to go get screened. And Dr. Jones, this brings me to something that you commented on in your presentation, is just the deficit of screenings that we have due to COVID. And so how impactful can something like a multi-cancer early detection blood test be? And how can we most effectively use that to catch up on that deficit? And what are maybe some, and then Dr. Lowell, I'll be interested in your thoughts here as well. What are some strategies that we could use to really press on that? What's missing to allow that to be as effective as possible?
Well, I'll pick up. I think that went to Candace, but I think it's really critical here. The MSEDs are not designed to backfill deficits in USPSTF recommended screenings, right? They are meant as a complementary test, not a competitive test. And so I think that the work we've been doing, we've caught up on many of these screenings, and I agree with Candace, the fact that we've really incorporated telemedicine finally. Zoom has a function other than seeing the neighbors, and it's really being put to use. So I think that's critical. I think we'll also continue to see Just like with colon cancer screening, not all colon cancer screening is colonoscopy based nowadays. Many tests can be done at home. And I think we'll see a trend toward that. And so I believe that incorporating, as we see it potentially and feasibly, as a part of the annual visit, part of that annual discussion, we see that is where MCED testing really comes in, part of a routine. And again, that access and having to take that day off of work, the MCEDs that GRAIL has developed have a very low false positive rate. So very few people are going to be having positive tests. And just for an example, our positive predictive value of the GRAIL, of the Gallery test, is 43%. Compare that to a mammography that's 4.4%. So for every one mammogram that finds cancer, you have 19 that were positive that had to be worked up and evaluated. And so by streamlining that and really cleaning that up, that's going to take a lot of pressure off of people to go work, do a workup for a false positive test, take off time from work, undergo unnecessary invasive or interventional procedures with those appropriate, those costs and everything like that. So I think it's a complete paradigm shift, almost like, doctors can't believe that we practice medicine before CAT scans. I think in 5 to 10 years, sooner, hopefully, we won't believe that we worked in the cancer space without molecular diagnostics.
Quick response to that, Dr. Whitney. I really love that perspective, and Dr. Candace as well. I really love you really viewing things from the low socioeconomic class demographics, and that's quite important in the work we do with health equity. And I see the MCEDs that's like Dr. Whitney said, it's not going to be a competition to the traditional test, but it's going to be a complementary kind of test to the traditional test. And for someone that works a low wage and works hourly wage and doesn't really have the time to take off work, it's really going to provide that kind of support, not as an alternative, but also it provides that opportunity to have access to what's not really there before. And while Dr. Candace was speaking, the importance of the social determinants of health really came out. And these are like key factors that really determine health even beyond the traditional healthcare systems. In the real sense of it, the way we viewed healthcare as the end has really been wrong. Healthcare from studies have only accounted for barely 20% of what leads to health. But unfortunately, we continue to invest in the healthcare component of it, provision of services, more services. But the social determinants of health that account for close to 60 to 80% of what leads to health is being left without enough investment in it. So we in the space of health equity has really advocated for how do we start understanding the importance of where people live, where they are born, where they play, where they work, and where they eat, the impact it has on their health. And healthcare in itself is not an end, but we should view it as a means to an end. And there are other components that lead to that end of health, which is a state of physical, mental, and social well-being. So I would like to pitch to this house, like how do we, as leaders in this space, to start advocating for more investments in the social determinants of health that has to do with educational piece, the economic piece, the neighborhoods, and social and cultural context, and how that relates to helping bridge the disparity gap when it comes to cancers. And I'm sure Dr. Whitney has witnessed this disparities real life, and I'm quite glad we're having this conversation today. Bobby.
Great. So I will get into that a lot more. And those are really great points there, Dr. Lowell, and I'm glad you brought those forward. So before we sort of really get into that too much here, I have one question I want to ask Dr. Westgate. You are at Adventist Health, and the AHEAD program there is doing amazing work with hereditary cancer patients. And so how does something like the MCEDs impact or complement the work that you and your colleagues are doing with AHEAD?
Absolutely. Thank you, Bobby. Great question. So just a quick little background on what the AHEAD program is. The goal of it is to keep you and your patients ahead of cancer, right? So it started as a small grassroots quality improvement project here in my OBGYN office, and then has expanded throughout our entire organization. And what it was assessing a patient's cancer risk appropriately by taking a good family history, determining those at highest risk, offering them genetic testing, and then managing those individuals over time. These individuals with the BRCA2 gene mutation, for example, have a significant high risk, not only for breast cancer, but ovarian cancer, pancreatic cancer, and melanoma. So a lot of these inherited cancer genetic mutations carry a significant high risk of not one cancer, but multiple cancers. And so these individuals, I'm seeing on average every 3 to 6 months in my office, and ordering on average 3 to 4 screening modalities on them a year, all with grades of sensitivity. We know how poor transvaginal ultrasounds and CA-125s are on screening for ovarian cancer, and the multitudes of research that has been done on population-based scale to try and find a better early ovarian cancer detection test. And it's not out there, unfortunately. And we don't have good societal guidelines helping us with a good screening test for those kind of cancers either. And so the amazing opportunity that MSEDs have in those high-risk individuals in regards to streamlining their cancer screening and enabling us to, with precision, be able to identify cancer at an early stage that would then be curable, that's a game changer. Right now, we're recommending hysterectomies and oophorectomies on BRCA patients at the age of 35. What does that surgical menopause do to the rest of their health? Osteoporosis risk, cardiovascular risk, sexual dysfunction, mood, mind, and memory. So the ripple effects that we have with those kind of, strong interventions, yes, they save lives, but at what cost? And so the excitement of this kind of test for those high-risk patients is really unprecedented, especially for those cancers that we don't have a good screening test for. So really excited about that. But at the same time, hereditary cancers only account for about 10% of the reason why patients get cancer. 90% of the population that get cancer do not have an inherited genetic mutation. Yes, they may have a family history. Yes, they may be exposed to significant carcinogens through their lifetimes. Yes, they may have other reasons for getting cancer: poor diet, smoking, drinking too much alcohol, et cetera, et cetera. And the joy and the excitement of this test is that it is appropriate for anyone across the board, specifically, and yes, most definitely those with a genetic mutation, but any individual with a cancer risk, and that is all of us.
Yeah, that's really well said, Dr. Westgate. And again, I'm so proud of your organization for doing great cancer family risk assessment. That's a first a starter, but it does go back further. I mean, I think the issues around disparity are really longstanding and systemic, right? And so not smoking, obesity, cancer-related habits, the lifestyle, food desert issues, all of the issues that sort of are the foundation of disparities. I think those all have to be addressed. But I also think that, taking the piece that our organizations are good at, which is molecular diagnostics, is really going to be that roundhouse. Our goal is to make sure that in the studies, as we push them out into clinical studies, that we enrich our populations with people of very diverse backgrounds. So we're not wondering, in fact, they work in African Americans or Hispanic Americans or people under 50 who have higher risk. We're trying to identify and evaluate that during that. And we have a commitment, I would hate to say it's in our DNA, that this test, as we said, is a joiner of groups, not a divider of groups. And I do think it comes down, you definitely cannot tell who people, what zip code they live in by their DNA. You can only tell that by their clinical outcome. So DNA may be that common thread that eventually brings us together as a nation and as a world, because this is a worldwide problem, right? Almost 8 to 10 million deaths a year and 20 million cases of cancer a year. So at GRAIL, we look at this as a worldwide problem in addition to a significant problem in the United States.
So Dr. Lal, and so thank you, Dr. Jones, for the nice transition there. So, you talked about applying the health equity lens on the front side. And in our discussion leading up to this panel, we talked a lot about access to care and how all these great tools are being developed, but there's not necessarily a plan to get them to the disadvantaged communities where they would be able to help address these health disparities. And Dr. Jones, touched on the social determinants of health piece again. And, I think it's notable talking about food deserts and things like that. Cancer isn't always the first thing that comes to mind when you talk about those type of health disparities. And so how do you think we can most effectively and efficiently get tools like MSID to these communities and really make a difference? Or is there a bigger picture? And you touched on this a little bit in your first comments. Is there a bigger picture that we need to settle on first before we can get into really addressing that issue?
Thank you so much, Bobby. This is quite critical to the conversation we're having today, and how do we make access universal with regards to these innovative technologies that can really reduce these potential disparity gaps. Let me reel out some numbers from the American Association of Cancer Research. African Americans have about 1.5 times higher prostate cancer incidence and about twice the mortality from prostate cancers. When it comes to colorectal cancer, they have as much as 25% higher incidence and about 39% higher mortality from prostate cancer. The same thing with breast cancer, about 40% higher mortality from breast cancers. Removing African Americans from the picture, you go to the Hispanics population, if you look at cases like stomach and hepatobiliary cancer, which I'm sure Dr. Whitney is so familiar with, you see as much as 70% higher incidence rates in the Hispanics and about 50 to 90% higher mortality from both gastric as well as hepatobiliary cancers. And if you now move to the Asian American population and Pacific Islanders, you have the nasopharyngeal cancers, about 7.7% higher incidence and about 7 times more mortality from this. Why am I reading out these numbers? These are facts. These are evidence-based facts that have shown we have these disparities. There's no doubt about that. But how do we now move this innovative technology, which are MSEDs, to make them as available as they are to this population as well, because they need it even more than the average Caucasian population, whether we like it or not. And what we've come up with in our organization of Bright Earth Group is to have a vision of ensuring everyone we serve have a fair and just opportunity to attain their maximal health potential. And how do we want to do that? We've identified by eradicating the barriers, which are the structural barriers, social barriers, as well as the economic and geographic barriers, to allowing people within this group to attain their maximal potential of health. And one of the key aspects, which I mentioned earlier, is how do we ensure that these groups, the African Americans, the Hispanics, the LGBTQIA+, the disabled population, as well as the Native Americans, are part of the decision making. It's quite difficult if at the end of the spectrum is when they get invited to the table. They've been, yes, when we start the production of this, when we start conceptualizing these ideas, if we have a diverse team, and if you look at the McKinsey studies, which was shared recently, they've shown that about 36% increment in profitability of more diverse teams compared to companies with less diverse teams. So beyond the moral imperative, there's an economic advantage of ensuring our teams are diverse. And that's like the cornerstone of really ensuring moving products from conceptualization of ideas to commercialization really goes smoothly through all this different diverse population. So the bottom line here for me is, how do we ensure from when we start conceptualizing these ideas and start producing these MSAs and many other innovative technologies, we have a lot of this diverse population included in the decision-making, such that we won't find it difficult to send these products to those communities. Because at the end of the day, what we're trying to solve here is to reduce the disparities, to advance healthcare within the United States systems. And for us to do it effectively and efficiently, more inclusive environments will really allow us to get this done. And if we're already at the end of the spectrum, we need to start thinking around, how do we have an advisory council kind of that is made of people at the grassroots that understand the potential reasons why this may not be taken up by the diverse population. So for me, I think really involving and including this diverse population in our discussions so they can guide us on how to really enter these diverse markets so as to really help reduce these barriers, preventing us from attaining health equity. And more importantly, we need to also look at the economic barriers. What is the innovative financial solution that we are looking at? Because we know many of these people in this diverse population fall in a lower socioeconomic class. It may be difficult for them to access this. So that's the point of financial access. How do we ensure while we are creating these products, we have an innovative financial system or innovative financial approach that we allow even fair, just access across board? So I think those are some of the points we may need to think about.
Thank you for that, Dr. Lal. And Dr. Westgate, do you have any thoughts on the question or on Dr. Lal's comments?
Absolutely. I am. Where to begin? So such a complex discussion. Where to begin? For us as an organization, our initial approach to this has been thinking outside the box in regards to how can we bring healthcare to our patients? How can we bring genetics to our patients? And instead of constantly expecting our patients to come to us to get the healthcare and the interventions that they need. And so that's where thinking outside the box is just like Dr. Lawala said, meeting the patients where their needs are. And that's going to be different based on different socioeconomic status, different needs, different access. And so instead of us as healthcare having this brick and mortar, environment where the patients have to come to us to get what we need, we're taking the approach of how can we meet the patient's needs in the location of where they're at. And for us as the AHEAD program, that's really started with point of care testing. And so instead of expecting our patients to go to another appointment to see the genetic counselor at another location, we're bringing all of those services to the patient via virtual care or to that office visit if they're able to make it in, and really removing those institutional barriers that are in our way that prevent our patients from getting the care they need where they're at.
Yeah, thank you for that. And I'm just going to follow up a little bit on that. So you mentioned at the beginning that you're an OBGYN, and until recently you were the Director of Women and Infant Services at Adventist. And so you're deeply familiar with the striking disparities in maternal health outcomes for women of color, which, as we are learning, are totally unrelated to location or socioeconomic status. So how can tools like MSID be leveraged to help overcome these type of systemic biases in healthcare? And I think you touched on one here, which is bringing it, meeting the patients where they are.
For so long in medicine too, and even in public health, our approach has always been trying to find, that one size fits all approach, and not looking at that person as an individual with unique risk factors. We've put everyone in a big box without really approaching each person as a unique individual. That being said, there is, just like what Dr. Jones said, our genetics are irrespective of our race, irrespective of our socioeconomic status. And so where one size fits all didn't really work, this could be a game changer because of the difference in our approach when it comes to genetics, irrespective of your ancestry, right? Irrespective of where you live, socioeconomic status, genetics is genetics. And so this is really an exciting opportunity for us to make a significant impact in a quote unquote one size fits all approach that hasn't previously worked when it's come to cancer screenings or risk intervention or risk prevention for our patients.
That's great. And so I'm going to flip the question here a little bit for you, Dr. Jones. We've talked a lot about how to use things like MSIT to overcome and address existing health disparities. How can we make sure that they don't exacerbate them and make the existing disparities worse?
I was so engaged in listening, I forgot to unmute there. So that's a great question, right? And the first step is going to be ensuring coverage, right? Until we have a different healthcare system and payer system in America, our first hurdle will be to get these tests reimbursed. And that puts in front of us the pathway to national coverage determination in the Medicare space. And that's already got a team of people, because usually once Medicare agrees, then the payers will come on board, and then hopefully we'll see accelerations in the Medicaid population and eventually some type of a universal coverage piece. But so coverage is going to be the first step. So that's the truth of the matter for the next couple of years. But after that, I think it's going to be really critical for all of our partners that we already work with, the American Cancer Society, Prevent Cancer Foundation, the religious community, various communities, to help educate those organizations so they can begin to educate the people who go through those for their health information, for their awareness, for their community organizations. And so, again, I think we've got to, and again, I see a great opportunity for educating physicians, much less patients. These are so new, and Candace can speak to this. We've had a hard time integrating people into hereditary cancer risk assessment and appropriate genetic testing. But because I think this is broader and has a greater impact, I think that we'll be able to get their ears, because our goal is that physicians still lead with this and are talking to people either on the Zoom or through their phone. Eventually is where a lot of this is going to happen, and communicating with them again in culturally appropriate languages and culturally appropriate folks, people who look like them, talking to people who are them. So we're going to have to figure that out. But I see three things. I think it's going to be reimbursement and payers, which means the federal government. Then I think it's going to be providers who have to get that next layer of knowledge. And then I think simultaneously, the word about a blood test that actually detects cancer before you have symptoms. Am I the only one thinking that I'm living in Star Trek world now? I mean, I think this is huge news, right? And I think the more that people learn about it and see it at that high level, the easier time we'll have in promoting this across and making less of a division rather than more of a division. But it's going to be tough the first couple of years.
Dr. Lowell, you've talked about this a little bit throughout your comments today, but just interested if you have any more thoughts on that question, how we can make sure we don't exacerbate existing disparities as we're looking to advance this technology forward.
Oh, thank you so much, Bobby. And that's a good comment from Dr. Whitney. How do we ensure that we have a right system through the payers, through the providers, and through the patients as well? Because we have to look at the 3 Ps and ensure that we are all working in sync and ensuring that, yes, we have the government on board through Medicare, like you rightly said. And hopefully for me, from the health equity perspective, we can also come from the patient's perspective up, because I guess the patient could be advocates for this if they've seen the benefits, in the sense that they get to see that this will benefit them and really reduce the disparity gap that they've observed in maybe their uncle, their grandparents, and stuff like that. So hopefully they may be able to be the front and center advocates of ensuring that this uptake is accepted nationwide. So for me, I think it's more from the grassroots. How do we ensure the acceptance by this different diverse population of this? And this can only be achieved through education, awareness. Like Dr. Whitney said, it has to be people that look like them, speak like them, and act like them. Saying it to them like, yes, we approve of this, and we all know the challenges with the mistrust in the health system. So until we are able, and I will always continue to clamor, until we are able to, across the spectrum of the development, conceptualization, and commercialization, embed the DEI lens in our organization, so that they don't think, oh, they developed this and they want to sell it to us. So it has to be, it is for us, by us. And for us to really reach there, yes, it's going to take a while, and it's going to take a lot of conviction. And I think really working with the grassroots and making them understand like this is for them, by them, then I think we may be able to get there faster if it's the patient being the advocate, and then the government coming from top down. So those are my thoughts.
Thank you. And so this has been a great conversation, and I'm gonna pivot just a little bit. And Dr. Jones, I'm gonna go back and start with you. So, we talked a lot about how MSID makes screening of cancer much less of a burden on patients, and something that can be really important if the nearest hospital, lab, or clinic is an hour or more away from where you live. And if as MSID is adopted on a broader scale, again, not as a replacement for the traditional screening, but as a complement, what kind of impact will we see on the health of people living in rural areas?
Well, I guess you asked me because I'm from Kentucky on that, right? So, and in Kentucky, it's really fascinating. We have equal rates of colorectal cancer screening between blacks and whites in Kentucky, but that hides the fact that we have very low rates of screening in Appalachia and very low rates of screening in urban centers where African Americans live. So I think it's going to be great. I mean, the density of specialists in the rural area is quite low. I think it's about 40 per, 40 versus 143, right? So access to specialists are limited. We envision this as potentially being part of a routine annual physical. So if people are going and making that sojourn to the doctor to do that annual physical, this could eventually be part of that. And so lessen the need for multiple pieces. The other piece that I think that's really important is that MSEDs that can identify accurately the source of the cancer really limit the diagnostic sojourn where you're like on a, Iliad and Odyssey to find out where these cancers are. So 89% of the time we identify the site accurately. That's going to allow people to get a prompt diagnostic workup many times in their local hospitals and not require referrals to tertiary or academic institutions. So that's a real leveling of itself that I think is critical. So I think those are the two issues that we'll deal with in terms of rural issues. But I think you can also look at that across access based on race or ethnicity, right? I mean, there's completely different patterns of behavior. We talked about how much does a darn colonoscopy cost, not just, even if it's free, it still costs you 2 days of work, and so I think the fact that MSEDs are going to simplify and really narrow the number of people requiring unnecessary workups for false positives is part of the game changer. Again, a person who gets screened for a cancer is 2 to 20 times more likely to get diagnosed with something else. So bringing all those cancers into the lens and the focus is going to change things and really alter us into that pre-symptomatic space, which I think is going to help a lot of people, right? I mean, I think farmers know they got to plant in the spring and harvest in the fall. I think folks of all colors and races understand a lot of these issues. We've got to communicate it to them and make the process simpler and adapt to their lifestyles. And I think the characteristic performance of MSEDs meet many of those goals.
Yeah, that's great. And you sort of answered my next question, which so now I'll maybe start with Dr. Westgate on this one. And then just any closing comments you have, Dr. Westgate. But just what type of overall impact will early screening, like from MSIDs, have on reducing the burden cancer has on patients?
Multiple, right? We know that for a lot of individuals that they only go to the doctor when they have a symptom, right? And then the comment that you get from them is like, well, I don't go to the doctor because my mom didn't go to the doctor. And when she did go to the doctor, they told her she had cancer. Well, that's because the patient wasn't compliant with her screenings, early prevention, pap smears, where we can actually prevent cervical cancer. Yes, colonoscopies, we can actually prevent colon cancer, right? And so there's still that mindset in and that distrust of the healthcare system, which leads to these kind of familial ideals of the fact that healthcare can't help us with anything. They just diagnose our cancer and we die because of that. Whereas if we're looking at MSED technology and its ability for early cancer detection, we may even be able to offer the patient surgery for that cancer and not even need chemotherapy. And the burden that places that on the individual, the morbidity associated with it, the time off of work, the suffering, and the ability to say to that patient, we caught your cancer early enough, this is not going to kill you, versus the flip side of that, where individuals present with symptoms and it's already stage 3 or stage 4. So for this to have a significant impact, it starts with that one individual who had the good outcome, right, and heard that good news. But for communities to engage in this and catch the vision of this for their children and for their generations to come, this needs to be expanded out into our population and be a population health initiative for us to see those kind of impacts on individual lives.
Great, thank you for that. Dr. Lowell, any closing comments from you?
Yeah, thank you so much, Bobby. And for me, I think we are at a point with cancer management, which the next decisions we make can either make or mar the bridging of the disparity gap. And for me, I think it's important we view things from ground up and really get people engaged at the grassroots level, and really making them see the reason why this is for them, by them, to really advance health in their demographics. So for me, I think it's really bringing those kind of people on board and really getting them engaged and seeing how that can be adopted. Because at the end of the day, if we have this fancy tests built from those fancy hotels and fancy offices, and a lot of our people are suffering and they're not able to really benefit from it, I think that may not really go well. So I'm sure with some of these conversations and the direction the country is going, with this momentum around health equity, we will put that in perspective as we move along with really rolling this out into advancing health and health equity. So I'm quite excited about the potentials.
Thank you. Dr. Jones, I'll give you last word.
Great. Well, thank you. Well, first of all, what an interesting panel discussion, and what an incredibly important topic as we really, I think, come into the 4th revolution of medicine, which is going to be the molecular piece. I think the first way we work in the disparity space is to take molecular diagnostics and add to the oncologist office where it's helping treat cancer better, and move it into that early detection space, with the hope that down the road we can move that into the preventative space as well. Because I mean, I don't think anybody here wouldn't rather prevent it first, early detect it second, and then rather treat it third. So I think that because of the technology, there truly is a value proposition in multi-cancer early detection, because the cost of sequencing will go down as we involve more people in our society and our population. I think the insights around it in terms of who really is at high risk and who benefits, not just based on age, but other factors. Again, we think about first responders. It was 9/11 not too long ago. Firefighters have a hugely increased risk of malignancies and cancers related to their environmental exposures. So I think the idea that we're starting off early, using DNA as the great equalizer and applying MCED testing, and we're looking at it and starting from a population-based health, because that's where we're really going to see these dramatic outcomes, is when we're really screening the population. I think we have a once-in-a-lifetime chance to really erase disparities and get down to that common piece that we all share, which is preventing cancer, detecting it early, and staying as healthy and well as we can, using technology to benefit us, not just to, help us at the end when cancer's already shown up and it's too late.
Well, great, thank you for that. And I'm really excited to see this technology continue to evolve in its use, and really be able to help address the health disparities and bring more access to cancer screening early for folks. So thank you to everyone for joining today. Thank you to our panelists, and this will be up online soon, so come back and watch it again. So thank you, everyone.